Hi, my name is Estefania Oliveros from Rush University Medical Center. I'm here today with Dr. Forfia from Temple University Hospital, and we're going to talk a little bit about the highlights of the meeting for you right now. How are you?
I am doing okay. So highlights for me, of course, I'm a pulmonary hypertension and heart failure cardiologist, and so I'm paying most attention to the pulmonary hypertension sessions, and I was able to participate in some sessions related to pulmonary hypertension and left heart disease, as well as the uses of cardiac imaging, specifically echo, in diagnosing various forms of pulmonary hypertension. So in pulmonary hypertension, left heart disease, I think the first thing is to emphasize that there are a few different versions of left heart disease. Most patients with pulmonary hypertension and left heart disease, they have the garden variety type of pulmonary hypertension where their left atrial pressure is elevated, their pulmonary vascular resistance is normal, and their right heart looks normal. That's the most common, and that's readily evident actually on a routine echo Doppler exam, and is just easily confirmed by right heart catheterization. But patients can develop a more robust and more severe form of pulmonary hypertension in the setting of chronic left atrial hypertension, where they can develop a very high pulmonary vascular resistance. Their right heart can become very dysfunctional, and they have a heart that looks something in the middle between a PAH heart and a pulmonary venous hypertension heart. So their left atrium may be big, but they may have mid-systolic notching of the RV alpha tract Doppler to signify a high PVR, and they may have RV dysfunction, or they will. So, and when we cath those patients, they have combined high left atrial pressure and high PVR along with signs of RV dysfunction. So I would urge people to consider pulmonary hypertension with an open mind and to look at your data, look at your imaging, look at your hemodynamics, and think about it critically before you just generically assign a diagnosis.
What can we do for those patients?
So the most important thing for a mixed phenotype pulmonary hypertension patient is to first and foremost, you have to pay close attention to getting the root condition under control. So if someone has mixed physiology PH, the first and most important step is diuresis and blood pressure control to get their left atrial pressure down. After that, you have to reassess, re-echo, re-cath if you need to, and if the patient still has a high PVR with RV dysfunction, then we're really forced to think about treating a patient like that if we can prove that that patient's symptoms and dyspnea and functional incapacity is related to the pulmonary hypertension itself.
Thank you so much for those pearls of wisdom.